This is the Owens Recovery Science Podcast.
Welcome back to Owens Recovery Science Podcast. A long time since we've been doing this, and so great to be back with all you fellas here. Actually, Kyle and Zach, y'all did do the Memorial Day podcast. Thanks for doing that, man. I've already got some comments. My sister from another Mr. Alicia White, who's at the VA, she texted me and said, thanks for a VA shout out. So that was cool of you guys to do that. But we're back. We're here to talk blood flow restriction again. We have new gear. We're like a pro studio here.
You and Ben are all, you guys twinkied it up today, huh?
Yeah. Well, we're representing.
Y'all didn't get the memo?
No, I didn't.
Branding, bitch. We're branding.
We're on video now.
Yeah.
God, dog.
The first question is, do these headphones make me look weird or not cool?
Because if
I'll drop this podcast quality in a minute. Do they make me look more bald?
Dude, these headphones make my butt look big.
5 head any worse. All right. So we get into things here, man. Let's just kind of do a little catching up. I'm in it's a time for change, fellas. My oldest daughter graduated high school 2 weeks ago. Jesus, I'm about to lose one. She's going to ASU, Arizona State. Ask this sunny side up, as I say at that school. It's I walked around the campus visit with her, and I was like, man, why didn't I go to ASU? It's a beautiful campus. There's some other beauty there. So yeah, I heard that they go to classes and the parties there in their swimsuits. I'm a little bit worried, but anyways, so losing one. I have a turtle that I lost as well last week around the same time as graduation. So did I tell you about my turtle?
No, this is news to me.
Yeah, man. So, I have this koi pond in my backyard. And one day there's this freaking turtle, like a big turtle, like not as big as like a flour tortilla, but as big as a corn tortilla in the koi pond. But he's real flat, like a different looking turtle. And he's just sitting there messing around. So I became enamored with this dude. I'm like feeding him, and the koi pond looked like a super salad. It had all this like lettuce and shit, and like carrots I was throwing in there. He's pissing the fish off. And then this dummy would just run and get into the swimming pool. And so I would get it. And then Melissa, my wife, would text me like, hey, the turtle's back in the pool. And so I'd have to go pull it out of the pool again. And then I started worrying about it. Like, could I leave it in the pool? And I called the animal control people, and they said, well, no, it's not good for him, obviously. And he said, probably the first thing that's going to happen is he'll go blind from the chlorine. This isn't a joke. This is a real story.
It's like you called animal control.
Yeah, I'm worried. Freddie, I love this guy, man. And so then I started worrying because I would have to go fish him out of the pool like 4 times a day. And he started getting to the point where I'd go after him and he would run like right into the wall. So I'm like, shit, I'm blinding this dude, right? Taking him out. And so I took him to my front yard. We have this big kind of fountain, and I put him in the fountain there. And he was doing great. And I overfilled the fountain one day on Memorial Day. We had family over. There might have been drinking involved. And he's doing weird things. Like he kept popping his head up and spinning around. And so everyone was telling me he's drowning. He's a freaking water turtle. And so they made me build this little stack of rocks for him. And the next day, gone. Left me too. So I still won't talk to these motherfuckers. I'm sorry, these losers in my house who made me lose my turtle, my daughter. I asked my wife, who's next? You. So anyways, enough about me.
Does your pool smell like chlorine, Johnny?
Yeah, it's got chlorine in it.
You know why it smells like chlorine? I just learned this.
A joke?
No.
Okay.
This is the real thing. Like that pool smell, you know?
I get it.
It's because pee in the pool.
It's not.
There is
pee smells like pee.
No. I saw the experiment. That Mark Roberg guy on YouTube, look it up.
So chlorine doesn't smell like
water
chlorine unless there's pee
treated
in the
it.
chlorine.
Unless there's pee in it.
So every
Unless there's
pool
pee
I've
in it.
ever been in had pee in it.
Exactly. Yep.
Because,
Isn't
that
that
chlorine
disturbing?
smell. Chlorine doesn't have the smell unless there's pee. So do they
correct.
pee in it before
You're
you
full of it,
actually
dude.
mix it?
Open
in?
I'm telling
a
you.
box of
Open-
chlorine, and
open the
it'll
little
make your
chlorine
face
pucks.
like fall off.
What do they smell like?
Yeah.
Telling
What
you,
is-
dude. I saw it on YouTube.
I almost passed out one time when I inhaled the chlorine pucks.
Yeah, what do they?
And I hadn't peed in the
yeah.
container.
What do they smell like? They smell like chlorine.
Yeah.
Right?
Just saying. It's the pee.
All
We're off to a good
anyways,
start.
We're digressing. This is why we don't do podcasts anymore. We can't stay focused.
This is entertaining.
So
I feel like I've learned more in this first 5 minutes then.
that's good. Today we're going to talk about a blog that I wrote. I've written 2 blogs in the last month. Have you mofos read any of them?
Yeah. I thought it was
Oh,
good.
y'all read them? All right. What'd y'all think?
Yeah.
Pretty good?
I liked it.
Yeah. Not ChatGPT either. My own self.
The
Put that out there.
the screenshots of the pictures from the studies were very unique. I'm sure that
Copyright. Damn it, Z. So anyways, so go to our website and check out. I did one about our recent unit going up in SpaceX, and NASA and SpaceX working together. I don't know if you guys know, I spoke at NASA about a month ago.
Yeah.
That's the most nervous I've ever been at a talk. And I've had to be in front of some serious people at talks, but dude, you don't know who is in that crowd. They're all like 5 PhDs. Only a quarter of them spoke English. Like from all over the world, like bone expert and So you just don't know the questions that are coming. But the coolest thing there is you're in front of a freaking IMAX for your talk. So the slides are like on an IMAX. That was pretty cool. But yeah, so anyways, we launched on SpaceX the first BFR system. They might have sent 2 up there, but they only used 1, which was
Wonder what the other
what I've
one
been
was.
told. Yeah, the Delphi system, and we're getting the data back, and we're gonna have Luke Hughes on to share the data. So that's pretty cool. So that's what's happened. I'll let you guys kind of fill everyone in too. So Kyle and I just finished a BFR and Achilles paper with Dr. Dracos from HSS. What else is out there? Gen 3, this is kind of just getting out, but Delphi has a new dope system coming out. Just saying, starting
Probably
to
just do a whole podcast on that.
yeah,
Just talk about
so it's going to be pretty cool. Got a lot of new features. And then I will roll into the blog talk next year, but you guys got anything y'all want to plug? Go to our website, check out our courses. We still got a bunch of courses everywhere.
Courses coming. Zach's writing a chapter. He just told me.
with Mark Maniago in the
With Menaggio?
Maniago.
Menago?
Yeah, Mark and I.
No, when you say it the real Portuguese way, that's how you say it. Menaggio.
Was that Italian or Portuguese?
They're right by each other.
It's me.
Marco Menaggio loves his lasagna. He works with the Parkinson's patients.
Yeah, when you spoke at NASA. Oh,
NASA what?
I was going to tell us about what you were
When I spoke
at.
at NASA?
You didn't.
Yeah, go ahead.
When you spoke at NASA, why were you there?
Because I was presenting about BFR in space.
Well, I know. I was trying to plug the conference that we helped sponsor.
Oh,
and
the
all
shop.
that.
It's for the shop conference. Yeah. What is this?
Space flight, human optimization and performance.
Spaceflight Human Optimization and Performance. Corey Twine runs it, good friend of ours. We've been working with the folks at NASA. We were one of the founding sponsors there and have been. And so, Luke normally speaks, and this year they're like, let's bring in the real deal. So they brought me in with Luke. We spoke together. No, I was like clueless of what they were talking about half the time. So thank God Luke was there. I'm just like, here's what BFR is. It's safe. Try it.
You should do it. But it's a cool conference. I mean, it's multidisciplinary.
Yeah,
I mean, there's probably not a more broad spectrum of expertise at that conference at any other conference that I can
Yeah.
think of. It's really impressive.
No, for sure.
So,
Yeah. Smart people.
Dietitians, engineers, physiologists, physicians, surgeons,
Astronauts.
astronauts. Just all walks of expertise in spaceflight.
Yeah.
Ultimately. So.
Yeah. I mean, that, like Johnny was saying, though, that group of people in that room, I don't think I've ever been in a room and felt like I was lower on the totem pole as far as mental capability than that group of people.
I bet that's almost your everyday of your life.
Well, hey,
So,
I'm in a room by
I mean-
myself right now, Johnny, so the bar is pretty low. So
No, it is. It is for sure. Yeah. Okay. What else? Anything else going on? Zach, you spoke at AOSSM.
Yeah, that was
Right.
back in March, I think.
That's how long it's been since we've freaking done this.
Yeah,
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 man.
that was good talk out there. Basically talking about trauma, and it was the limb salvage kind of special interest group. So talked there about the benefit of BFR, and it's unique to have a good perspective of the different stuff out there. I think I sent you the picture of the one guy who spoke from the University of Colorado, where they were basically on amputees with the prosthetic. They were just literally going right into the femur versus doing
Osseointegration.
versus a socket or like a vacuum type system. And the one thing I mean, for folks who work with amputees, I'm sure that it's common knowledge, but the one thing I never really thought of or considered is the effect that you have up the chain, like basically into the hip, and how much it wears the hip, and then you accelerate OA into the hip, and then you just lead into total hip and so on, whereas you don't really get that abnormal loading or those abnormal forces into the joint, and it helps preserve up the chain. So
We hope, yeah. It's still waiting to see, but yeah, it's pretty cool. That was like the holy grail when the war
Yeah.
started. It was like, dude, one day if they could just put this in the bone, and I was like, that's like Star Trek, bro.
Yeah.
No way. But yeah, we were us and Walter Reed were one of the first sites where they really started looking at doing that. So it's pretty cool.
It's
crazy.
it's so much like I mean, if you've ever really worked with an amputee, between them donning and doffing the prosthetic, I mean, it takes so long. Whereas with these guys, man, dude, it's just on and go.
Well, the skin breakdown, and then the fatty infiltrate and the loss of the soft tissue envelope, it's just bone, basically, as you get older. So Zach, if you could do osseointegration, and they said, we're going to make your prosthetic 3 feet tall, so it makes you 6 foot tall, would you go for it?
I mean, I would.
I always freak out when I mess with Zach because of his sniper background.
you don't know if he's ever too far away to take a
I
shot at
know.
you, Johnny.
I think that the blades that they're coming out with, I mean, I just really wonder one day if we will get to the point where mechanically, from a mechanical advantage standpoint, that we develop a material that is far more advantageous to what our tendons are able to do.
Yeah.
Yeah, I mean, and that was the whole argument with Oscar Pistorius. Yeah, right. That he had an advantage. Yeah, I mean, like that would be the deal.
Till he started shooting people. Of
I
course,
mean,
that was a problem.
Well, he was fast at least. All right, man. So that's enough banter.
back to chronic ankle instability.
Chronic ankle. Okay, here is our podcast. So hopefully I haven't lost our whole 2 listeners. Here is my genesis of coming up with this blog. So we did the baseball winter meetings. And by the way, that's another podcast we're going to have because we got something pretty cool potentially coming out with baseball and throwing with BFR, with some research being done. Anyways, we're there, and it was about recovery and arm and blah, 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 blah. And then we did the NFL meetings, and it was all a lot more about recovery, but also post-surgical and things like that. And then I'm going to speak at the NBA Combine meetings a couple weeks ago. And Jeremy Linecky and I and Brittany Forbes, and Jeremy, he gets like my NASA thing. Tell us about BFR and then tell us it's safe. Just chip shot. He didn't even change his slides from our talk we did like 7 years ago. And so, and then they're like, Johnny, and then will you give us an update on BFR and basketball injuries, like soft tissue and ankle sprains? And I'm like, I got nothing, man. I mean, can I do Jeremy's and he does the hamstrings?
That's when you want to go, haven't you all done the research?
Yeah.
You're the basketball people.
Yeah. Well, as you know, there wasn't a lot, I didn't think. And so we wrote, me, John Faltus, Corbin Hett, a hypothesis paper, like 2018 or so, about how you could use BFR potentially for chronic ankle instability. And so we put that paper out, and here's the things we're talking about. Because of the low load nature, the short lever arm of the foot ankle, and then is there something to balance and proprioception we could do with this? And we'll get into why we think this could be advantageous for people after ankle sprains. And so since that paper, there's been 7 chronic ankle instability studies that have been done, which I didn't know there was that many, which was pretty interesting once I started looking at it. So some of them are crap. Hopefully those people aren't listening. But some of them are interesting, and I think it's just going to set the stage of why this could be an intervention for something like an ankle sprain or chronic ankle instability. Here's the background then. Ankle sprains, again, for the NBA, the story, it's 25% of injuries. It's the number one injury in the NBA. That was Dr. Dracos, actually, our buddy who put that paper out about that. But people who have an ankle sprain, about 40% go on to be a chronic ankle instability person, where it's a nagging issue and they're rolling their ankles all the time. So it's a problem. Happens a lot, and it can become a chronic problem. I had a soldier who had so many ankle sprains and just dusted off his cartilage so much they had to fuse his ankle because we just didn't have an ankle replacement, and it just became so arthritic. So I mean that's kind of an extreme. So what we want to do now is get into the concepts and into these papers. So I set the stage. Do you guys have anything y'all want to add before we talk about these papers?
I thought the recurrent injury rate was interesting, and how it's basically doesn't matter gender. The recurrence is like 5%, which kind of got my brain sort of wandering a little bit on injury rates and recurrence. And supposedly because you know how like when you start talking gender differences, people immediately start to go into ACL because there's such a difference there. But apparently when you start talking re-injury, the gender differences just kind of go away. They're not a thing. And so it just makes me kind of wonder even more like, well, why do women tear their ACLs more frequently? And it seems to maybe only affect ACL, not so much the ankle. I don't know. I haven't seen gender differences on the initial injury, but
I didn't see anything out there.
Yeah.
Definitely on ACL though. That's another podcast for sure.
Yeah, for sure.
Okay. Have you guys ever done this for ankle?
Yeah.
Acute sprains.
Yeah.
Acute sprains, and then people who are kind of chronic out. Yeah.
That's Zach's whole story on his wife and his first son.
Yeah,
Axel.
that was a fracture.
Remember? Because Axel was real big. She fractured.
Because your son was too big?
No.
Yeah.
Well, I thought Kyle said because he was so big.
He came out.
He was so big.
What, 10 pounds?
He came out really
10
big. And
pounds.
so Zach was convinced that it was because his wife did BFR.
Yeah.
But the BFR thing,
Yeah.
That's just like Alicia. Her son was big.
But no, I did it. I sprained my ankle, man, roughly probably 60 hours or so before the first time I went to Montana to hunt. And man, I have pictures and a video like the pitting edema that I ended up getting. And I tell people all the time, I kid you not. That was on a Wednesday. That night, I just did heel raises and like mini squats with the cuff on. The next day, no pain whatsoever. Friday, I did hop test, everything. On Friday, I got video and pictures of this. I then flew to Montana on Saturday and I hunted all on foot, backcountry, walking. I put in probably close to 60 to 70 miles on foot in the mountain without issue. And I mean, yeah, I have pictures, video. I got pictures of my leg. The bruising is still there, like in my tent, but yeah. No, I honest to God's truth.
That would have been nice for my blog, Zach.
Yeah.
Pictures instead of my screenshots of the
pictures.
stolen
I
pictures
got
that
video
used.
like
Great.
legit pitting edema. That was on Thursday or Friday, and then flew to Montana Saturday morning.
So definitely the pain thing we've talked about before. The edema thing I think will be interesting to talk about because we all get that question. I think enough. So interesting. Okay, so here's I'm going to follow the flow of some of the way I looked at the papers and what we think. So the first one is Killinger, and it's Brian. I never can say Brian's last name right. Gochius. Getchius. Yeah, he's a friend of ours. Has been doing some decent amount of BFR research. So anyways, what they wanted to look at was because ankle exercises are inherently always going to probably be low load if you're just isolating the ankle. Is there a way, because it's low load, you could just do BFR and see higher muscle activation and lower oxygen? So more hypoxia locally in the muscle. If you have more hypoxia in the muscle and it's working, then you inherently should start getting some of those larger motor threshold units. And here's the problem with the foot and ankle. If you try to do eversion, inversion, dorsiflexion with your stupid TheraBand, the lever is so short of the foot and ankle that you can't ever get enough leverage on it. So even if you add more TheraBand, your patients just sit there and they're doing hip external rotation almost. You just can't get like a 70, 80% of a rep max probably with these TheraBand exercises. So it's inherently low load. So they put the cuffs on. They used Delphi at 80% limb occlusion pressure in this study. So it's just an acute study. Come in, do these inversion dorsiflexion exercises without BFR, and then come back another time and do it with BFR, measure EMG, and measure, did you get hypoxia locally, which means you should get fast twitch. And they showed that it did increase muscle activation and it reduced oxygen content. So eversion strength was significantly higher, 5.6%, dorsiflexion, 7.7%, not strength, I'm sorry, muscle activation. And oxygen levels were reduced by around 31 to 44%. Lastly, the subjects said it was hard to moderately hard when they were doing BFR. So their RPE also shows, if you use RPE scales for lifts, it was hard versus the just regular exercises. They said it was easy. So anything you guys want to add to that or any thoughts on that? Makes total sense to me.
I think you were getting there with your description, but I don't know if you said it specifically that it was isometric contractions in this study. So it was 2 second hold, 2 second rest for reps that they did in the images that may or may not have been copied show the setup where they're actually showing how they set up the isometric exercise, which is, I think, pretty cool to look at how they set it up so you could easily set it up yourself.
Yeah. And isometric with BFR is hard. I was doing it in Ben's office the other day with the new Gen 3, and it might have an EMG sensor with it. Spoiler alert. And just trying to get that muscle activation isometrically. Holy crap, dude. I could barely get through the first set. I was smoked when I did it. Now, it would be nice to have a dynamometer so I know like how much output I'm really doing. But yeah, it definitely wore me down. Okay. Anything else you guys want to add to that? It's pretty straightforward.
No, that was the isometric was the main one. Because we get asked that a lot.
Yeah.
Mm-hmm.
How would
to
you do isometrics?
And so
Time, reps?
yeah, I mean that's usually what I say, but I think they did 2 second, 2 second
Yeah, 2 and 2.
contractions. So
30, 15, 15, 15.
and
But they did
and
it at,
saw those changes that
they did it at 30% of a 1 RM.
Mhm.
Yeah, and that was the thing.
They had-
30% of
they
an
had a thing.
isometric max. And
Yeah.
so they were doing it with some sort of visual feedback
Visual,
so they can
yeah.
actually see when they're getting to that 30% mark.
Mhm.
So
Yeah, which you
again,
can get with your EMG.
yeah.
Exactly.
Or not with your
Mhm.
EMG. Sorry, with
Biofeedback.
Biofeedback, yeah.
Yep.
Dynamometer type. Okay.
So I thought that was cool that we had, at least an example of isometrics.
Mhm.
Whether or not that's the absolute best way to do it remains to be seen, I think. How did you do it when you were doing it in Ben's office, Johnny?
I was
What are
doing
you doing?
rotator cuff against the wall, and I just did the first 30, and I said, get this damn thing off me. I'm smoked.
But what were your holds? What were your hold durations?
Like 2-2.
Okay.
He was, kind of going
I
with
was trying to make the EMG.
the other new feature on the device, the metronome. So he's trying to kind of keep it biofeedback following the metronome, which is also a kick in the ass.
Like we need a whole podcast, like you said, on this Gen 3, but with the metronome and the biofeedback or the
Yeah.
EMG, first it breaks your brain because you're trying to figure it out, but it's in a good way. But dude, I have a picture of me doing leg extensions in my gym, and I had to drop set like every 4 reps because trying to get that muscle activation, I did not get through the first set of what I normally could do with BFR because that effort was just so much harder with that EMG. And I talked to Jeremy, and he's like, yeah, well, that's why we get good results in the lab. And you guys' clinic results suck because we kind of use those type of things, So
Yeah,
this will take it, I think, to the lab type setting. So this paper was set up for this next paper, NAGD. So this was actually an RCT. And so they did 4 weeks of exercises with or without blood flow restriction 3 times a week in chronic ankle instability athletes. And their exercises were 4-way ankle. They didn't say band or weights. I think it did say cuff weights. And then they did a sequence of balance exercises for both groups. But during the ankle exercises, they had BFR. They didn't have BFR on during the balance training, just the ankle exercises. Yeah, I had to really read into that, Ben. I'm pretty sure that's what it was. I see you side-eyeing, but don't side-eye
Well,
me.
if it's the
I
90
wrote the
paper,
blog, bitch.
I thought they had BFR on only for the proprioceptive balance exercises and not the resistance exercises. But that was just
For
it
the
was kind of
NAGD?
wonky to read.
NAGD?
Yeah,
No.
that was
I'm
my.
pretty sure.
Yeah, I think it was
Pretty sure. Oh, shit.
with resistance is
Yeah, I could be wrong.
yeah.
The other note that I
Patients-
Saying
had
that
was,
you were
patients
just reading the
allocated-
papers today.
Patients allocated to the BFR training groups receive low load resistance exercise 20 to 40% 1 RM using a tourniquet around the thigh proximally to the knee joint to occlude blood flow 50 to 80%. And then
There you
it doesn't really mention anything about BFR in the proprioception. The methods were definitely a little vague in this, but
Mhm.
they perform proprioceptive exercises for 30 minutes, 3 times a week for 4 weeks, progressing from static to dynamic.
Yeah. And so, unfortunately, they only tested dorsiflexion, plantar flexion strength.
Mhm.
So that was a problem. But they did show when they retested their strength, they had gotten significantly stronger on dorsiflexion and plantar flexion. Let's see, dorsiflexion increased 73% versus 19% in the control group. Plantar flexion increased 67% versus 27% in the control group. Part of why Kyle and I are suggesting this for Achilles repairs. And then they checked the foot and ankle assessment, the FAM, and the BFR group, which checks stability and giveaways and all that sort of stuff. The BFR group significantly improved 24% versus the control group, which didn't, was only 13% improvement. So self-reported and stability improved, strength improved. But what we don't have is any long-term, I wish on these, could you just call them at 6 months and see if they've had any recurrent injuries? I mean, it wasn't that many, 34 people, but okay. I think if anyone's ever tried to do isokinetic inversion, eversion, inversion on a Biodex, it's just stupid. I don't think the validity is
plantar flexion's hard enough.
Yeah, that's why just do isometric. So that might be why they only did. I think dorsiflexion, plantar flexion at least has some validity compared to inversion, eversion. But improved strength, improved. They're self-reported. You guys have anything y'all want to add to that one?
There's another paper we'll talk about, but the outcome measure that they looked at was the foot and ankle disability index, and there was about a similar change over the same 4-week period. It's like I think it was a 14, 15-point change. So it tracks with that, that you're getting not just the strength change, but this is actually translating to things that are relevant to the individual.
Yep. The next one then, kind of my progressions of thought here, was the Burkhart paper, again from John's coach's lab. And this time they looked at balance. And then we can also look at, from their group as well, Clark looked at balance. And this is similar to their first trial where we talked about they were measuring muscle activation. They had a crossover design where you did Y balance exercises with BFR on or without BFR on. So we'll talk about the Burkhart one first, and what they wanted to see was there an increase in muscle activation in the lower extremity that you're doing balance on with BFR compared to without BFR. And with BFR, they did show a significant increase in muscle activation. It was primarily in the vastus lateralis, and it did increase quite a bit, had a really large effect size, 0.86, or a large effect size. So you really forced the quad to start working more in the BFR group. And then the soleus also had a significant increase, although the effect size wasn't giant. It was 0.32, so it was smaller effect size, but there was increased muscle activation whenever you did blood flow restriction compared to the same exercises without. They didn't see changes in the inverter. What was it? It was just everters, right? Fibularis longus, I think. Yeah, maybe in tib anterior and fibularis longus. Postural instability, they reported it was harder with the BFR on, so they felt like they were more unstable. So this might be why the muscles really working more, as well as the hypoxia and rate and perceived exertions were all up significantly higher in the BFR group compared to just doing the Y balance exercises without. Again, 80% LOP, doing that same 30, 15, 15, 15. So each reach on the Y balance was a rep. And so instead of timing, they did that, which is also pretty cool. Just to jump into Clark next, since they're similar, then we can discuss this. Same thing, same group, crossover design. These are all with chronic ankle instability people, so these aren't with healthies. Again, 80% LOP. This one was another Y balance one. But what they wanted to see this time, and this was done actually before the other one, I believe, is do you get more instability while you're doing balance exercises with blood flow restriction? And they showed that they did. So significantly reduced their anterior reach. And the overall, the STAR composite score was down by 9.3%, which is significant. And the RPE, the subjects all said it was much harder doing these balance exercises with blood flow restriction versus without. So I've got lots of thoughts. You guys, what are y'all's thoughts? More muscle activation, but it's harder when you're doing it, even though it's kind of like low load exercise with BFR. It's harder, but the load's lower. The balance exercises were not that challenging, but significantly, it was much harder for them to do.
Mm-hmm.
I kind of wonder if this works sort of in reverse as how like we think downstream fatigue works proximally, where you kind of fatigue out that quad and then start to challenge the ankle musculature more over time. I wonder if you're not seeing kind
Or
of a
more
similar
glute,
sort of effect.
more proximal
Yeah,
control.
for sure. Definitely could be.
Well, this gets into the whole internal versus external load. So myself, Alex Franz, I'm forgetting everyone that was on it. I think Luke did a paper last year in Frontiers of Physiology about BFR's internal versus external effort
Patterson
that
was on
you
that,
get.
wasn't he?
Who was that?
Wasn't Patterson on that?
Probably, yeah.
Yeah.
And so what BFR does is it gives you this an internal load that you don't get with regular exercises. So external load would be how much weight you're putting on there, what your exercise is, how many reps you're doing. Internal load is all the muscle metabolites that are building up, the muscle activation that's happening, the central command that's having to deal with what in the heck is going on here and why do I have all these metabolites. And so that internal load can be a way maybe to safely challenge something like balance exercises. You're forcing people to feel like what they would feel like during a game or later phase in a game, even though you're not having to make them do circus tricks like stand on a Swiss ball or a Bosu. You're challenging them internally first to kind of get them primed to then start working on more of an external locus.
Yep.
I just wanted to plug
also,
my paper, really. So
I like the way that they
about me.
set up the target reps. I mean, it essentially trying to follow the 30, 15, 15, 15. And just since they were doing these multi-directional movements and there was, 3 touch points, they just kind of broke it down that way where each touch was a rep. So you've got, the first time you're doing it 10 times through, then you've got 5, 5, and 5. Because again, like the common question that I get when people are talking about it with balance, like, can I use it with balance training? Sure. Okay, how? It's like, well, I mean, it's kind of up to you. You could do it for time. Maybe you could do it for reps, but it's nice to have a model that's rep based that we could share. So
yeah, everyone likes standardization and protocol, but then I think if you look at this internal load type thing, it's like this, let's get them to fatigue. Whatever way you want to get them to fatigue is what we're doing there. And I'm sure 30, 15, 15, 15 dynamic exercises is going to get you to fatigue for sure. So yeah.
About 6 minutes of exercise, right? Or more.
6 minutes of balance training. You get rest.
Yeah, it's funny, Ben. I would have read the reps and been like, oh, God dang it, here we go again. Because like when people start asking protocols, I just start thinking, I think you're missing the point on BFR entirely. You're not understanding that this is just a means of kind of, in some ways adding load because you're adding something that fatigues. And so, yeah, I would have gone more Johnny's direction, but I see your point, could be a good thing. At least that works and does something,
Yeah.
It's not doing nothing. It's doing more than without BFR.
Anything for you, Zach?
No, I mean, I think the from an acute standpoint is pretty consistent. What you get is earlier onset of fatigue. You get an increase in RPE, an increase in rated perceived instability. So it lets you know you're taxing what you need to tax or what you ultimately want to address. Muscle activation increases. So from the acute standpoint, we get all that. And then now, I mean, I think it's a matter of, are we going to build from that acute standpoint? What does this translate to this individual, over a period of time? But, like laying the groundwork on, an acute session, we do see that difference, and let's go from there.
Yeah, that's, I think, just from programming, right? You get acutely, and it's like, now I can get you in here, and I can just have you do a standing on the ground doing maybe just static balance or a little bit of dynamic reaches day 1 or 2 post ankle sprain. I'm not freaking out. Like I actually re-injured a young service member, having her do too much, I think, balance wise. She rolled her ankle again. So this is a way, I think, especially if you're limited in visits, man, let's just go. You get this internal like load, and it's challenging them early on, because you probably don't get 12 visits for a sprained ankle anymore. I don't know.
Yeah, I think it really ties in with, you know, how I think about BFR is you have that acute injury or whatever the acute situation is. You're limited in what you can do. How do we maximize what we want to get out of the session? Then how do we use this to progress to where we ultimately want and need to go? And if we can get that RPE effect and the rating of perceived instability, like this person feels taxed and they feel like unstable with what they're doing, that's what we want to do. And we can do this in a very controlled, lower level environment, and then hopefully build from there, make them increase their confidence, increase their perception of stability, and then start to progress them into the more kind of taxing type things in the later phases.
Yeah, and it's like 6 minutes, done. And then just go. Then maybe do some functional things when you're in that fatigue state. So maybe program this where it's earlier in your treatment session. Right. Okay. The next paper, a little bit not as amazing. I've never, this name, there's no freaking way. We'll have the citations in our show notes, or go to our website and look at my blog. I have like 40 citations in it. College folks with chronic ankle instability 3 times a week for 6 weeks. They did BFR or the same exercises without BFR. And their exercises were heel raises, squats, double leg on Bosu, single leg Y balance, and then they would progress the balance exercises over time. This one showed, so anyways, they progressed that over time. They did not see changes in balance in this study, or changes, I believe, in self-reported. They did see increases in strength in the plantar flexors and the everters, even though they didn't even do any eversion exercises. And they also saw that there was an increase in cross-sectional area of the fibularis longus, but really didn't see much change other than the little bit of strength, but didn't see change in balance and didn't see change in self-reported in this one. Here's maybe one of my problems with it. They said they did 80% limb occlusion pressure and they used a pump-up cuff. So I don't know if they maintain pressure with these folks. If you want to get an internal load and your cuff is just like losing pressure over time, your internal load is probably going down as the pressure's leaking as well. Because the ones before, they actually used surgical grade. You guys have any thoughts on that one? It was a H+ cuff. And that would be a lot of BFR. Bilateral heel raises, bilateral squats, double leg Bosu balance, single leg Y balance. That's one session at the start, and then they just made it more challenging with their balance exercises over time. Dude, if you're doing that with like serious BFR, you're freaking smoked, bro. I don't.
I just don't understand the bilateral thing.
All of it.
Unilateral injury to begin with.
The ankle sprain, and we're going to be doing squats.
Was this also the one where they measured with a different cuff than the cuff they actually applied the BFR with? Or is that...
Lord, really?
I don't think so. I don't know. I didn't see that, but that would be stupid.
Yeah.
We've seen people do that.
Yeah.
All right. So, yeah, whatever. I don't know if they were able to keep occlusion, especially if you're doing that many exercises and trying to keep it at 80% the whole time. The next one, it's a little bit interesting to me. So they did ankle joint mobs for dorsiflexion in ankle sprains, chronic ankle instability, or they did ankle joint mobs without BFR. One round. Stay with me. And then they checked their Y balance after that one round to see if the increased dorsiflexion improved their Y balance. And it did, especially in anterior reach, which is one of the main ones you want to look at with chronic ankle instability, because they do start to lose some of that dorsiflexion. And it improved, I don't have the numbers here, but it's a 1.25 effect size. So like friggin' massive improvement if you did a MOB with blood flow restriction and chronic instability for dorsiflexion. Thoughts, fellas? Y'all want me to do this in my 1920s voice again?
Yeah.
They saw remarkable improvements in dorsiflexion. He was able to do the cha-cha-cha all night. His anterior reach was impressing the ladies. Does that make it better?
Yep.
I
That
feel like I
landed better.
totally understand it now.
Yeah.
I don't like this being recorded because while I was doing that, I could see my eyeballs were getting bigger the whole time. Okay, Kyle, you have a question.
Yeah. So tell me again the groups. There was a group that got MOBs with BFR,
Yes.
and then the other group did what?
Just got MOBs.
Just got
no
MOBs.
BFR.
No BFR. So there was no.
It was like a mulligan, whatever. What do they
Mobilization
call
with
it?
movement.
Yeah.
And
So there was
WM.
no
I took that.
just
Snags.
BFR.
Do you do NWMs?
Snags and
Snags.
Snags and nags. Oh, yeah, man.
man.
I had that little book.
Yeah, that's a dirty
I
book.
took that mulligan thing a long time ago.
Yeah.
Look, it's all crap, but sometimes it really helps. the
No,
people.
I've had some
I
stuff
think
really
my
help
wife
out of that, but
with her shoulder problem, I did probably an MWM, maybe a snag or a nag. It's just some of it's so wonky, like wrapping the towel.
yeah. Yeah.
I'm like, okay, you got that for home? Patients are like, yeah, sure. I'm going to do this one at home. Okay, so anyways, you got it, Kyle?
Yeah, I've got
Okay.
it now.
Improved. I don't remember if they measured dorsiflexion, which you would hope they would. I didn't see that. But it significantly improved their anterior reach. So I don't know. Maybe if you've got a acute ankle or a chronic ankle and you want to restore dorsiflexion, I will say this. My wife had a frozen shoulder, and I put BFR on her because I was just having her do some little exercises, and it was frozen, but it was also pain limiting up to a point. When I just had the cuff on her, I was like, let me try and, I didn't do an MWM, just trying to work on her range. I definitely got more range with the cuff on. And it's probably like the hammer on your thumb with a headache. Like she's probably like, all I feel is this stupid cuff and everything. But I was able to get more range when she had the cuff on.
So back to what I was saying when I sprained my ankle and I did standing.
Oh, it always comes back to your little ankle. I was able to kill a moose later that week.
With this. So I don't do it in open chain doing the mobilization. What I do and what I've had patients do is closed chain. And what I tell them
kneeling
is no standing, like mini squats. But I said, I don't care how far you squat down. It's all about how far your knee goes over your toe. So I need your knee to go far over the toe, as far as you can get it with intolerance, what have you. So it's a closed chain dorsiflexion movement. I really believe that is what made the difference. And, purely anecdotal.
Yeah.
But that is the thing, like I've done with patients and so I think there's something to the mobilization aspect with it. And
do exactly what your protocol would be then. You put the cuff on 80% and you do the squats for what, like 30, 50, 50,
single leg. And they can use the table for support. Like I don't care about any of that type of stuff. All I care about is closed chain dorsiflexion. And I mean, like I had a lady, this lady was, she had a PhD in something. She had a very significant sprain. The doctor put her in a boot And I saw her right when she came out of the boot. She still had pain, like walking and all this stuff. And then like throughout the treatment, after like a few weeks, I'm like, how do you feel? Like, how's your pain? And she's like, I haven't had pain since the first visit. And I was like, all right, that's fine.
We've all had that.
Well,
right?
I mean, I'm not saying that is.
Yeah, no, but I
what
get
I'm
what you're
like,
saying. Yeah.
I do like that is what I do with people, and I've had really good results with closed chain dorsiflexion with the cuff on, set of 30, 3 sets of 15. Again, it's not about how far they squat down. It's closed chain dorsiflexion, and then work into some heel raises, like whatever they can tolerate, and things have typically
badass,
have
actually.
done pretty decent.
Yeah, I like it. Well, and we've heard this. Even when we had Morkos on this podcast, he was talking about how he likes to do this with his mobs. And I remember, Ben, do you remember Walt Lowe at Memorial?
Yep.
And so he's the surgeon, was the Texan surgeon, Rockets. He was saying that his therapists were able to get the knee extension back, post-op ACL, if they would work on it while they had the cuff still inflated. And that was kind of something that he was like, have you heard of that? And that was a long time ago. We're like, well, no, not really, but that's pretty cool. So, okay. All right, so maybe we can get the dorsiflexion back. Maybe try it with a cuff on if you're struggling. Maybe it just distracts them.
Yeah, maybe don't do it the way they did it in this paper.
Yeah, do it the way Zach does it. I think that's close chain's the best. No, I like it. I like it.
Yeah,
Balance, internal load can happen with it. Do it for time, do it for reps, however you want to do it. You can maybe start it early. And then BFR is made for low load. Ankle exercises are lots of times low load, and when they're open chain especially. So BFR can be something that will make it more hypoxic and increase muscle activation. I just solved all your ankle problems right there, MBA.
Boom. Boom.
You're welcome. You are welcome. There was no time for questions because I spoke too long, so I don't know. No one asked me.
No.
Yeah. I only had 6 minutes. 30
Is that all?
slides, 32,
Oh, man.
32 slides.
Heck yeah.
Oh my word. Well, I know I saw the slide, so yeah.
Yeah, they look good. It was pretty cool because I had to use the BFR template, so they made them look sexy. Any final thoughts on chronic ankle instability and BFR? Give it a shot. Why not? I think there's something to it. Maybe we'll get a really good RCT that looks at this. Maybe MBA fund us with some of that MBA grant money that's out there.
I think principally, it's a similar. You would approach it similarly in like the wrist hand. Just in terms of mechanical advantage of things and your ability to really elicit kind of those internal loads. I just think of them as kind of being similar. And, you don't ever think of giving people exercises for their fingers or hands that really creates fatigue.
Mm-hmm.
If you've ever done just seated row with BFR at a light load, your grip is gassed.
Yeah. Well, it's the whole lateral epi thing. How do you really load that tendon?
Exactly.
It's like, tendons need load, and then it's like 1 pound weight when you have lateral epi. And you can barely grip because it hurts, so you get that analgesic effect.
Yeah, so I think conceptually the BFR makes a lot of sense in those regions. It's just hard to put it into words to help people kind of understand why, if you will. So
ChatGPT it.
Yeah. I'm not sure what words to load in to ChatGPT to get it to spit it back out. So
I know.
Makes sense.
When is
That's the tricky
ChatGPT going to
part.
just give me answers without me having to ask it?
think for you.
Is that the next update?
Yeah.
All right,
well,
man.
I mean,
Any closing thoughts? Go to our website, sign up for courses, read these blogs, find my lost turtle, Freddie.
Freddie?
Don't buy me a turtle. I don't want
I'm gonna
one. I
find-
just want Freddie back. My daughter, whatever. She's
I think there's
gone.
probably some kind of editing thing we could do to where we could turn you into a turtle for part of the podcast, Johnny.
That's great. Go for that.
If you want to, yeah.
All right. All right. It's good to do it. Let's get this going again. So when's this going to come out, Kyle?
This will probably come out quick. I'm going to edit it today. I'm going to
Oh, yeah.
try to
We're not
get it
supposed to
all
talk about
done.
that
So
because no one knows when we recorded it or when it actually comes
within a
out,
day,
so.
within a day or two.
Okay. Awesome. Good talking with you, fellas.
Yeah.
Talk soon.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.
One last thing before we get out of here. First, want to say a sincere thank you for listening all the way through, but also wanted to remind you that this podcast should not be considered medical advice. It is strictly entertainment. It's a way for us to try to keep up with what is ongoing within the BFR world. If you require some sort of medical attention, medical advice, please seek that from a licensed individual within your state. Thanks, and we'll talk to you soon.